Hello, I'm Dr. Bardia Anvar of the Skilled Wound Care Program. This is your weekly update for June 5th, 2012. Today I will be going over gastrostomy tube issues and the skilled nursing facility. We generally place gastrostomy tubes in patients right into the stomach. And the reason why we do this is to directly feed patients directly into their stomach to bypass their esophagus and their swallowing if they're unable to swallow. And we also do this if sometimes patients need an extra little hand getting some extra nutrition into the body. Now, gastrostomy tubes, the advantage of this is that we're feeding directly into the stomach and we're not feeding nutrition through the vein or peripheral, so it's preferred to always feed the patient through the gut. Now, this is a bypass going directly into the stomach. This is a balloon gastrostomy tube. And it's important to always note what type of tube the patient has placed in. This is, of course, your stomach. Your stomach goes down your duodenum. When gastrostomy tubes are placed, there's two options for placing gastrostomy tubes. One is a percutaneous endoscopic gastrostomy tube, which is otherwise known as a PEG, or a surgically placed gastrostomy tube, which could either be a PEG, usually it isn't, it will be a balloon type gastrostomy tube. Most of the tubes, initial tubes that you will encounter are PEG tubes. And PEG tubes are placed through the endoscopic route. They're placed at the bedside and they're much more minimally invasive than taking the patient to the operating room. But the one thing to remember, if you admit a patient to the nursing facility with a PEG, if the patient's PEG tube comes out for any reason in the first 0 to 6 weeks, like so, the PEG tube comes out, and the PEG tube will usually have a button at the end. If it comes out of the stomach, do not attempt to replace the PEG tube and refeed the patient. If you do so, you may be refeeding the patient's peritoneal cavity, and it can be in a surgical emergency. Let's say I decided to blindly replace the tube at bedside, specifically in a skilled nursing facility. I would have a tube that may or may not be in the stomach, and I could possibly be feeding the peritoneal cavity. What that causes is specifically called peritonitis, and that has a 50% mortality if it is left undiagnosed within 6 to 8 hours. So we never want to blindly replace a tube that has only been placed for 6 to 8 hours. Of course, call us if you ever have a tube that has been displaced so we can tell you exactly what to do. The other thing is that if the patient pulls the tube and it's been in for longer than 6 weeks, and then at that point, what the facility can do is go ahead and place a temporary Foley catheter or a temporary tube into the tract. Do not start feeding the patient, and call us to come in and replace it for you, and we could visualize exactly where it has been placed. I don't recommend leaving a gastrostomy a Foley catheter as the feeding device for a gastrostomy tube, because the Foley catheter will go backwards and forwards in the stomach and the outer tract. It could also cause obstruction in the stomach, and it could cause all sorts of problems. Specifically, it could cause leakage, and it could cause hypergranulation tissue. A lot of times we see patients and we get referred for what is known as peristomal dermatitis, and it could be a fungal rash. It usually has to do with the acidic contents of the stomach actually leaking out. And when we look at the stomach, inside of it, what we have are rugae. And as the patient is fed, the orifice of where the gastrostomy tube is opens up, and then we note to see the leakage coming around the outside of it, and we get the peristomal dermatitis, which can be very uncomfortable for the patient. The best way to manage that, obviously, is to treat the dermatitis with special skin medications, and at the same time upsizing to a larger gastrostomy tube to cover the area so that there is no leakage there. Now notice, if the tube is missized for the hole, it will always go back and forth, and it could be dislodged a lot of times. So you always want to upgrade the tube if you're changing it. Now, we are a surgical service, so we can change these tubes in the facility. However, if you would like to change them on your own, we recommend knowing exactly what kind of tube you are putting in, and we highly don't recommend doing this in case for that 1 in a million case where you put it in the wrong site and you don't actually replace it in the patient's stomach. It's almost inexcusable. So this is your stomach. Your stomach leads to the duodenum with the jejunum and ends at the ileum. And when we place a jejunostomy tube, we're actually placing it directly into the patient's jejunum. We can do this through interventional radiology or through an actual surgical procedure where we take the patient to the operating room. In all instances, if you have a jejunostomy tube that comes out, never try to blindly replace a jejunostomy tube. This is highly unorthodox and should never be done. What happens long-term to gastrostomy tubes? Well, as they stay in the stomach, these gastrostomy tubes slide back and forth in the stomach. This sliding of back and forth causes the patency of the hole to increase, and suddenly you will start to have leakage manifest itself at the outer surface of the skin. This will cause a peristomal dermatitis or a rash around the stoma of the gastrostomy that can only be fixed by upgrading the gastrostomy to a larger gastrostomy tube. The other thing that nurses should always be aware of is to make sure that the gastrostomy tube with its button are tightly fitting against the stomach and the skin, making sure that the tube is not going back and forth. Now, we have seen on plenty of occasions nurses have replaced a balloon gastrostomy tube with a button with a Foley catheter. The Foley catheter does not have the button here that holds the tube in place. And what does that cause? It causes a back and forth going in and out of the stomach, which can cause multiple problems. The worst problem that it could cause is a gastric outlet obstruction if the tube goes all the way into the patient's stomach and goes to the pylorus, which is the emptying part of the stomach, which is something we don't want. So that's why it's important not to use Foley catheters as a gastrostomy tube. Secondly, as it goes back and forth, it also stimulates hypergranulation tissue. So it's very important to make sure that the tube is snugly fit there so that you don't get that hypergranulation tissue. Hypergranulation tissue can be treated with silver nitrate over 3 treatments, and the hypergranulation tissue usually disappears, and these tubes can be changed to a larger tube so they're not slipping back and forth through the stomach. If you have a patient that pulls a gastrostomy tube, it's best that you call our services to come in and change those tubes for you. If the patient has the tube pulled and we can't get there right away, make sure to place the patient on IV fluids, place a temporary Foley catheter in the tract to keep the tract patent. These tracts close within 2 hours until our services can arrive and change the tube for you. If the patient is a diabetic, make sure that you are also giving the patient sugar, water, so that we don't have any. Now, that's our review for gastrostomy tubes. I'm Dr. Bardia Anvar. This is Skilled Wound Care, and we will see you on the field.